Hi everyone, and welcome to our module on vertebral basilar stroke syndromes. So let's start by reviewing the vertebral artery anatomy. So right here we have the two vertebral arteries on the left and the right side of the body coming up off the subclavian arteries on the left and right side of the body. And they're going to fuse together and form this basilar artery that is a midline structure. At the bottom, they each give off a posterior inferior cerebellar artery, and then they both together give off a branch that goes and forms the anterior spinal artery, which is another midline vessel. Up here off the basilar artery comes two anterior inferior cerebellar arteries, and then way up at the top we have the superior cerebellar artery. And basically all these vessels supply the brainstem, so when you're talking about strokes of the vertebral artery system, you're talking about brainstem strokes. So this is the map I use to remind myself of the brainstem's blood supply. Over here on the right I've drawn the midbrain, the pons, and the medulla, and I've written the cranial nerves that you can find at each level. And you'll notice that I've drawn 3, 4, 6, and 12 all near the midline, and that's because those are medial cranial nerves. The other ones are all lateral. In the module on the brainstem, I talk about how to use something called the rule of fours to localize brainstem lesions to the lateral or medial side based on the cranial nerves, and you should watch that module after this one if you haven't watched it already. Over here on the left side of the screen, I've written the major blood supply. Now this is by no means complete. There are many more vessels that supply blood to the brainstem, but these are the ones responsible for most of the significant clinical syndromes. So the PCA, or the posterior cerebral artery, is what is responsible for most of the midbrain syndromes, both medial and lateral. In the pons, the basilar artery gives a medial syndrome, and the anterior inferior cerebellar artery gives a lateral syndrome. And then down in the medulla, the pica gives a lateral syndrome, and the anterior spinal artery gives a medial syndrome. And we'll talk about all those in this module. But if you can remember this slide, it can be very helpful during your exam to quickly recall which blood vessel is likely to be responsible for a lesion at which level of the brainstem. So the first stroke we'll talk about is a SCA stroke, and this is the rarest of all the cerebellar strokes. Both the SCA, the AICA, and the pica all supply the cerebellum, and of those three, this one is the most unlikely to cause a stroke. Pure SCA stroke gives almost all cerebellar symptoms, so patients will have ipsilateral cerebellar ataxia. So let's talk about what that would look like. So a patient who has an ataxia on one side of their body, if you ask them to put their hand in their palm and flip it over back and forth, they won't be able to do that with the affected side of their body. Also, if you ask them to touch their nose and then touch your outstretched finger, they won't be able to do that on the affected side. So that's how you can localize ataxias to the left or right side of the body. And then patients with an SCA stroke will also have nausea and vomiting. In reality, SCA strokes often affect more than just the cerebellum, and they're hard to distinguish from AICA and pica strokes, but what I've described here comes from the rare case reports of patients with pure SCA strokes. A basilar artery stroke is called the locked-in syndrome. It's also called the ventral pontine syndrome. So let's take a look down here on the right. So ventral means anterior, and so this is an anterior pons syndrome. And in red, I've drawn damage to the anterior pons. So what would you lose if that area was damaged? Well, you'd lose the corticospinal and corticobulbar tracts on both sides of the body. So you would have bilateral paralysis or quadriplegia. This would include the arms, legs, and the face. The only thing the patient would still be able to do is blink because the upper brainstem is intact. And that's why this is called a locked-in syndrome. Patients can feel and see the world around them, but they cannot respond to it. And contrast this with a vegetative state. That's where patients have intact motor function, but their cortex isn't working, so they can't process the world around them. Central pontine myelinolysis is also called osmotic demyelination syndrome, and this is something that happens when you raise patients' sodium level too quickly. So these patients get demyelination of the central pontine axons, and they have a big lesion at the base of the pons. They lose their corticospinal and corticobulbar tracts, and that's why it can be very similar to the locked-in syndrome with quadriplegia. And so this happens when someone presents with hyponatremia to the hospital and their doctors raise their sodium level too quickly. If you're going to infuse saline to raise someone's sodium level, you have to check it frequently and only raise the level at a certain speed, and the reason for this is to avoid the central pontine myelinolysis syndrome. The top of the basilar syndrome is very rare. This is where you get an occlusion of the upper basilar artery. It's usually embolic. So these people have damage to the areas that affect our consciousness, so they can slip in and out of consciousness and be in a coma. They also get damage to areas of their visual function, so they can have hallucinations and blindness. Other eye problems like a third nerve palsy, and they can lose their vertical gaze or have problems with convergence. But they usually have no significant motor loss, so that's what helps you identify this as a top of the basilar syndrome. Basically, you're going to look for someone with confusion, sort of slipping in and out of a coma, who has a lot of eye symptoms only. So those are all very rare vertebrobasilar stroke syndromes, but these ones are the big three, the AICA, the pica, and the anterior spinal artery, and we're going to talk about those now. So an AICA stroke is called a lateral pontine syndrome. So let's look down here on this picture of the right of the pons. And in red, I've shown the area that could be damaged by an AICA stroke. So what would you lose if you lost that area? Well, you would lose your vestibular nuclei, so patients would have nystagmus and vertigo and nausea and vomiting. You'd lose the spinothalamic tract, so the contralateral side of the body and the arms and legs would not be able to detect pain or temperature. You would damage the spinal nucleus of cranial nerve 5, so on the side of the body with the stroke, the ipsilateral side, the face would not be able to detect pain and temperature. And you would also damage the sympathetic tract, so you'd get a Horner syndrome on that side, and we'll talk more about that in a minute. The facial nucleus is in the lateral pons, so you would get ipsilateral facial droop and you would lose your corneal reflex. And then the cochlear nuclei are in the lateral pons, so these patients have hearing loss and deafness and maybe tinnitus. And they would also lose taste in the anterior portion of their tongue from cranial nerve 7. So Horner syndrome happens when you get compression or disruption of the sympathetic nerves and ganglia. So recall that the hypothalamus sends fibers to T1 in the spinal cord, and then it exits the spinal cord and comes back up. Well, to get from the hypothalamus down to the spinal cord, you have to cross through the medulla and pons. So damage to the lateral portions of that part of the brainstem gives you a Horner syndrome. Horner syndrome is meiosis, so you have small pupils, ptosis, which is a drooping eyelid, and anhidrosis, which is lack of sweat. And clinically, you usually can't detect the anhidrosis, but these two are usually obvious. So these patients will have small, constricted pupils, and remember, it may not be described as meiosis. They may say the pupils are unequal. And if they say that, the Horner syndrome is on the side with the smaller pupil. They'll also describe a drooping eyelid and lack of sweat. So all this is a Horner syndrome, and it happens with brainstem lesions that affect the lateral pons and medulla. So next we'll talk about a pica stroke. This is called a lateral medullary syndrome. It's also called Wallenberg syndrome. So down here on the right is a drawing of the medulla, and in red is the area that might be affected by a pica stroke. So what would you lose in that area? Well, the vestibular nuclei are also in that area, so you can have nystagmus, vertigo, and nausea and vomiting. The vestibular nuclei are found in the lateral pons and medulla, so they help you localize a lesion laterally, but they don't help you figure out which level it's at. The sympathetic tract runs out here, so you can get a Horner syndrome. The spinothalamic tract runs out here, so you can get contralateral pain and temperature loss in the arm and leg. And then the spinal nucleus of cranial nerve 5 is also here, so you will get facial loss of pain and temperature sensation on the side of the body with the stroke. So all these things are very similar to the AICA stroke and the lateral pontine syndrome. What's unique to the lateral medullary syndrome and what helps you sort it out is damage to the nucleus ambiguus, which involves cranial nerves 9 and 10. So these patients have hoarseness, dysphagia, and they have lost their gag reflex. So finally, we'll talk about the anterior spinal artery stroke. And remember, the anterior spinal artery is a midline structure right here. It can cause damage to either the medulla or the spinal cord, and in both cases, it's going to damage midline structures. Let's talk about an ASA stroke at the level of the spinal cord first. This is sometimes called the anterior spinal artery syndrome. Recall that the anterior spinal artery supplies the anterior 2/3 of the spinal cord, so if you have a stroke in this vessel, it will lead to damage of all the areas I've indicated in this drawing on the slide. What this means is that you will lose motor function and sensory function except for the posterior columns. Thus, only vibration and proprioception will remain intact, and there will be bilateral paralysis below the lesion. So this leads to a very strange physical exam. The patient will have bilateral paralysis. They will have decreased sensation below the level of the lesion except for vibration and proprioception. Those will remain intact. So if you see that strange constellation of signs and symptoms, that should remind you of the anterior spinal artery syndrome, which is caused by an ASA stroke at the level of the spinal cord. Now, if it's at the level of the medulla, then you get what's called a medial medullary syndrome. So you get damage to the corticospinal tract, the medial lemniscus, and cranial nerve 12. This will give the patient contralateral hemiparesis and contralateral loss of proprioception and vibration. It will also give you flaccid paralysis of the tongue, and the tongue will deviate to the side that's got the stroke. So this is an interesting thing about the ASA. In the spine, it can't destroy proprioception and vibration because those things run in the dorsal columns in the back. But when they get to the medulla, they synapse and cross to be near the front, and thus the ASA stroke can destroy these sensory functions when it's at the level of the medulla. So here I've summarized the 4 most important vertebral basilar stroke syndromes. In the AICA stroke, you have damage to the lateral pons, and the key findings that help localize it are facial droop and hearing loss. In the pica, you have damage to the lateral medulla, and the key findings are dysphagia and hoarseness. The anterior spinal artery, if it affects the medulla, can give you contralateral motor dysfunction and tongue deviation. And then if it's in the spine, remember you're going to lose bilaterally motor, pain, and temperature with sparing of vibration and proprioception. And that concludes our module on vertebrobasilar stroke syndrome.